kaboom that happened during surgery. This was a patient who had a submacular hemorrhage of this size, and he was given a intraocular gas bubble and TPA injection and anti-VEGF injection, but the hemorrhage moved down and surrounded the macula. So now we went in to operate. After doing a vitrectomy, this is we are injecting the TPA injection into the subretinal space. You can see the bleb rising very nicely, and this is the bleb completely encircling and just going beyond the margins of the hemorrhage. Now, at this point, this was a reasonably sized bleb, but then I thought that because most of the bleb is superior, even if all this blood hemolyzes, it will still be under the macula. After doing an FAE, I realized that probably this needs a little more fluid, or the bleb needs to be a little larger, because it's mostly superior. So then I went in again, I restarted fluid, went in again, I started injecting, and to create a bigger bleb, and this is what happened. So this is in slow motion. There was an air bubble in the syringe, and fluid goes in slowly, but the air rushes in very fast with the pressurized injection. And this is now me staring at what has happened suddenly. There is subretinal air, there was a blowout, and kaboom, there was a hole at the macula. So then I decided that, okay, let us proceed with the surgery. Let me see the extent of the damage. So we stained it with the trypan blue, and the lesion, or rather the tear in the ILM that we could see, was a linear tear. So this was the configuration. Now I had a strange, problem. I planned to do ILM flap, but then the ILM has, come off from the edges of the hole also. So on the go, I started to think of how I can create a flap. So this is what I did. I started the ILM peel on top of the bleb. This must be the only case where you're peeling with air underneath you. So, so this is how we did it very slowly. This was all basically thinking on the trot. Nothing that you've seen or done earlier will prepare you for this. So first I started peeling on one side, and then I carried this to the other side also. And as I was expecting, yeah. So as I was expecting that, the ILM was quite loose at the margin. So luckily I, did not try to create a flap from the margin like we routinely do in ILM flap. So I decided that let this be a kind of a pedicle flap where the ILM comes from a little farther in. So this is the ILM peeling that I've done around the macular hole, and this was the flap that was remaining. And then this was a large flap. So I kind of, with a very low suction, I trimmed it with my cutter. Again, being a little foolhardy, but anyway, that's what I did. Then I did the fluid air exchange. And after the fluid air exchange, the fluid air exchange got complete with the soft tip. And once I had completely dried the retinal surface of all the fluid, then I took this soft tip, but this time the soft tip is attached to a syringe which has the plunger in, so there's no suction. And with that, I positioned the flap over the macular hole, and this was the end of surgery. We left it with gas tamponade. So this is the post-operative picture after about 2 weeks, when the air actually, I left it with air, so air had completely absorbed. There was a little bit of subretinal hemorrhage, which you can still see in the OCT. The macular hole is closed. And this was about 1 month after the surgery. The macular hole is closed. Patient eventually at 6 months has 6/12 vision. So I think I was lucky there to escape, even after such a, I would say, surprising and shocking event that happened intraoperatively. Eventually, we were able to get a decent result. Thank you.
Excellent case, Dr. Abhishek. I think it's you are very lucky, and so is your patient, that you got away with this. But there is a lot of skill that is involved in doing this. So I would like to invite Dr. Sangeet Mittal. He is one of our speakers, but sir does a lot of these macular surgeries for AMD. So, sir, quick comment from you, please.
Two things I would like to say. One is, if you use an automated injection in this case, the chances of the macular blowout is less as compared if your assistant is pushing the TPA.
So we use automated, sir. We use automated.
It was automated. Okay.
But the only problem was that, when the fluid goes in, there is a little bit of resistance, but there was an air bubble which I had not noticed. The air because it is compressible, it goes suddenly with the jerk.
Suddenly, yes. And the second thing is like doing a ILM peeling, especially in patients in whom you are combining the TPA with air. After the injection is very difficult. So in those cases, I would plan to do a ILM peeling beforehand rather than doing it later on.
No, the ILM peeling was not planned, sir. ILM peeling happened because there was a blowout.
But if in your case it's okay. But if you are planning a combination of air and TPA, then I think you should do an ILM peeling beforehand, because ILM peeling becomes very difficult when the air is below the retinal surface. I think I don't know what others' experience is.
Can I ask Dr. DAD madam to give her comments on this?
This is a very interesting case, and I don't think this sort of complication has been reported, although people are doing subretinal TPA injections. So very interesting, Abhishek, to note this. What I would like to know is what was the etiology of the subretinal heme in this situation?
AMD, ma'am. AMD.
AMD, okay. So was it possible that maybe the fovea was already a little bit, damaged or not in a very healthy situation? There must have been some, retinal edema or something. Maybe that led to this kind of already a weakened macula, and that's why the fovea gave way. Had it been, say, a traumatic situation, maybe it might not have happened, because you don't expect the fovea to be damaged. But maybe AMD caused it to give way. Yeah, good, very nice video. Enjoyed it.
Dr. Kshitij has a...
Yeah, so can I make a quick comment? A very interesting complication and very nicely managed, Dr. Abhishek. So of late, in Disha and particularly Dr. Boral had initiated, and subsequently most of us are now following this. So of late we have started using the cocktail mixture for submacular bleed, particularly the old one. And in that, what we are using is, we are using a mixture of ranibizumab along with air and the TPA. So the volume is quite large, and as you said that towards the air has gone inside. So even I faced a complication like that, and luckily the hole was not subfoveal; it happened parafoveal blowout, because the large amount of fluid and the air which we are going to push inside. So I waited for the the second phase surgery, and the patient we are going to take it up again. But yes, very nice.
Thank you.
I'm sorry to interrupt, sir, but the time is running out.
Thank you.